weeks. That's why the theory says that in the first 2 to 3 months, you see a lot of shrinkage. Generally, the buccal bone is thinner than the palatal or lingual bone, right? So when you have any tooth that undergoes resorption, you see the effect on the buccal plate more. And unfortunately, guys, where the aesthetic comes from is the buccal plate. Okay? Aesthetics, recession, that's it. I drew this diagram for you. So basically what this means, the bone on the buccal is usually very thin, so you will see a more exaggerated resorption pattern after 2 months. You heard about this article, that the buccal bone slowly in dogs starts decreasing after 8 weeks, and very interestingly, the lingual bone stays the same, yeah? Because it's thicker. This picture that you have here, I'll speak a little bit more in detail for the aesthetic pause. But this study, what came out from Professor Boozer's team, he said that not all extraction sockets heal or resolve the same thing. So he had a group of, I think, 28 patients, and this is what he did. He took CBCT on the day of extraction, that means he took the tooth out and he took CBCT. And just before implant placement at 2 months, he took CBCT. So what he wanted to do is from day 0 to day 8 weeks, what is the change? So in their research facility, okay, the software would superimpose the two CBCT image. Okay, when you have a lot of bone change, it appears as red. When you see the bone change as yellow, it means medium bone loss. If you see green, green means cool, means no change. He found out in his patients that if the patients come into your clinic on the first day, if the buccal bone is more than 1 millimeter thick, what happens after 8 weeks? Very little change. You see? Huh? If his patient comes in with less than 1 millimeter bone, look at the bone change. It's a lot. So this is something I didn't know about until this year, 2013, and I started to realize, wow, not all sockets heal the same. And then our Asian socket is so much thinner. So that's why I have more of the WTF, right? I see cases, and that's why I started doing more socket preservation. Someone was asking me, because previously I didn't used to do it. So I started changing my concept for the anterior maxilla. That is to be reserved for the next one. Okay? Now, there's different degrees of resorption patterns. Some more, some less. It all depends. If you have a more trauma, more infection, yes. If you have thinner buccal bone, yes. Huh? So the post-extraction healing that we learn in dental schools can be divided into 4 basic categories. Okay, take the tooth out, you cause injury to the tissues, you have blood clot. So the blood comes in, and then you have the inflammation. I told you inflammation is actually good. You clean up the wound, the infection, the white blood cells, the plasma cells, the lymphocytes. And once everything is cleaned up, that's when you have the granulation tissue to come in. So these are the early tissues. These granulation tissues, they are genetically programmed. Some will turn to bone, some will turn to soft tissue. And then finally, when it becomes bone, it becomes osteoid, meaning without the mineralization. And then with the calcium coming in, then it becomes calcified. Okay? So it takes a while for an extraction socket to happen. So in the first few days, you have the formation of the blood clot. Okay? This is without bone graft. And then comes the second stage, which is the wound healing that happens in the first 2 weeks. And then after that is the early and late granulation tissue formation. You have the cells coming in, and then slowly tissue maturation. The bone starts becoming more calcified. One thing to learn from this diagram over here, and you see that all this while the soft tissue takes so long to close. So that's why in your extraction socket, when you're dealing with a lower anterior, it closes very fast because the space for the gums to jump is very small. But if you are dealing with a molar side, it takes a long time. So sometimes you see a bit of a depression, that's okay. This diagram over here, 6 weeks, will tell you that's when the complete collagen happens for the soft tissue formation. That is why in periodontology, in gums, when we root plane and scale, we do not probe until 4 to 6 weeks later to check the pocket healing. Because you need time for the soft tissues to heal. Because if you scale today and then you check next week, it's not going to be. The 6 millimeter will still stay 6. Okay. So this study, that they looked at human biopsies after extraction, they found out that vascular supplies happens immediately and then it starts decreasing after the second week. So you have the blood clot and then it starts slowing down. Osteoclast means bone resorption happens at 1 month, but the osteoblasts will only start coming in after 6 to 8 weeks. So the bone formation, which is the calcified form, will come later. Okay? So at least in the ITI classification, in terms of timing protocol, they divided into 4 classes. Okay? Other groups will have their own. Okay? But ITI came out with 4 classes. Okay? Basically, type 1 is what we know as the immediate. And if you look in the literature or in research, many schools, they define immediate very different. Some say extract today, place 1 week later is called immediate. But the definition means today, immediate means today. Extract, immediate, placement today. Okay? So we follow the definition. Alright? Type 2 and type 3. Type 2 is a little bit early, 8 weeks. Type 3 is called early, but you allow a little bit of bone filling in. So 2 months, 3 months. And then type 4 is what you call the delayed filling. 4 months, 6 months, 12 months, 2 years. Okay, but they classified it as type 1, 2, 3, 4. I will talk to you a little bit more in detail one by one. Okay, type 1 is placed immediately, extraction on the same day. Okay, it has to follow the definition. Type 2 and 3, you extract it. Type 2 means complete soft tissue closure. And what we say, it happens around 6 weeks. Type 3, you have soft tissue closure and you have the socket at the base starting to fill with bone. So it's about 3 months. So type 2 is about 2 months, type 3 is about 3 months. And of course type 4 is 4, 6 months and later. So this is a nice timeline, okay? So you have immediate, type 1, the early placement, which is just soft tissue healing, that's 8 weeks, 2 months. You have a partial bone healing, which is 3 months, and then longer than 4 to 6 months. Now, when patient comes to see you for their missing teeth, do they tell you, hey Dr. Yo, can you do a early implant placement with you? No, they can't tell you this, right? Because they do not know. It depends on us. Whatever timing protocol, we need to achieve this kind of success. It doesn't matter whether we do early, we do immediate, or do delayed. We have to see whether, at the end of the day, the outcome gives you this kind of results. Okay? These are cases where I did it with bone level implants and tissue level implants. They work the same. It's the concept. That's why I'm here, not to really sell implants. I want to sell you the concept. It's the technique. We do it in single tooth gaps. We can also do it in multiple tooth gaps. Can you imagine we put the case from here to come to here? Yeah? You see that? It's very difficult. But if you were to follow the protocol and the evidence, you can do it. You see? We did it with bone level implants and we did it with tissue level implants. Type 1, immediate implant placement. Same day of extraction. Advantages, people like this. No? This was developed by the Americans. Everything, they want it quick and fast. So they say that if you extract and put it immediately, you can do 2 things. You reduce the visits, reduce the surgery, and then you can fill up the hole straight away. That was the thinking back then. Okay? The disadvantage is that you have a hole and it's empty. If you have an acute infection, you can't put it in. Okay? And then placing the implant in a big hole is not easy. I would never recommend, I say this again, I would never recommend immediate implant placement to someone who has never tried implants for the first 10 to 20 cases. Okay? So you want to stick with the S classification. Keep it easy, really. Because immediate, I do sometimes about 10 to 15%, but not all the time because it's not easy. Trying to put the drill into the remaining bone. And if you have no skill, the drill keeps on slipping and then that's it. Okay, so don't try that. So you need to be very experienced with high technique sensitivity if you want to do immediate. Immediate works, but not all cases. I will show you some immediate cases that I did. Okay? So this patient came to see me, and it looks something like that. Tooth has to be taken out. And if you realize right now that this is not Straumann drills, because these are one of my first few cases that I started learning implant. This is an Astra system. We analyzed the situation. The bone was quite nice. The soft tissue was quite thick. And the patient has no smile, high smile line. So I said, this is quite easy, very low demanding. So I tried immediate. You see, tooth comes out, implant goes in the same direction. And this is how it looks like. You fill up with bone and then you place the tooth immediately. You can do that without any occlusion. So you know it works. Case number 2, patient had a punch. Sometimes I have to raise a flap. My recommendation, if you can not raise a flap, don't raise a flap. But in cases where you need to raise a flap because of trauma, because you have to see sometimes foreign objects go inside, you have to raise a flap to remove that fish bone or broken bone, that kind of thing. So sometimes you have to raise a flap. But already you can see it. The bone is so thin. And then you put the implant in, you pack it with bone, and then that's it. You put in a immediate provisionalization. So you know it works. Okay? In some instances. Now, the study shows that you have a very good survival rate, 95%. Friends, we talked about this morning, do we go for survival right now? We try not to. We go for success. The studies that's available for immediate implant for about after 1 or 5 years is 95% survival. Not too bad, but they don't have long studies. In some of the papers they looked at, after 1 year, 46 studies, they found out that survival is quite high. So we know that survival for the implants to be inside the mouth is going to work. But the problem about immediate implant is that the amount of research out there is not a lot. You see, studies that had 4 years or more, only 2. So you are basing 2 studies for a midterm 4-year follow-up to decide whether immediate it really works. Now there must be a reason why they didn't report a 5, 10, 50 years. Right? Very obvious. Maybe it doesn't work. Okay? Right? There might be. I'm just thinking. They found out that thin biotype and buccal bone, thin buccal bone positioning will not make your immediate cases successful. So if you see a case with high aesthetic demand, thin biotype, maybe don't do it. If you see a case that has, you can't place the implant palatally, don't do it. You try and then you stop. You say, you know what, forget it. Socket preservation, you see the patient 3 to 4 months later. Sometimes you change your treatment plan. 20 years ago, it was proposed that immediate implant placement, when you put inside the socket, they thought it was like socket preservation. Put something inside, you will slow down the bone healing. But is this true? Because they started noticing that on average, it's about 1 millimeter recession. 1 millimeter to me is not so bad. We have 1 millimeter recession, but this is 1 millimeter is average. Ladies and gentlemen, you have to look at the data very carefully. When you look at average doesn't tell you anything. Average just tells you, out of all these people, what is the monthly income, and you say here, on average, the monthly income of these 35 friends over here is $5,000 US dollar, for example. But is it true? No, because this guy here, he earns 100,000 USD, and everyone else earns $100. You understand? then the average becomes 5,000. So that's how data sometimes can be twisted. So you have to look inside the data. So when you look inside the data says that for the severe recession, how does it feel? 1.5 millimeter recession, 2 millimeter, this is quite a lot, right? When you look at the severe recession, you look at the percentage. You see the percentage, it's not fun. For something that has 2 millimeter or more recession of 20%, it's not fun. Look at this study. Joseph Kahn is from Loma Linda, an American that does a lot of implants immediately. This is his report. More than 5 millimeter recession, a very severe recession, 1/3 of his cases. So if he has 100 patients, and he reports an average or a mean of 1 millimeter recession, but when you look at the data carefully, more than 5 millimeters, 33%, that's crazy. What does 33% tell you? Every 3 patients, one has a 5 millimeter recession. Are you going to live with that in your clinic? No, you can't. Because every 3 patients, one will be a complaint case. Every 3 patients, one will be a complaint case. Then your clinic will be called Dr. Alvin B.K complaint case clinic. Really, you'll be managing the aesthetic recession all the time. And can you see the impact? When you look at data, you look at average, yes. And then you've got to see, is the average, true average, or a they call it a skewed average. Okay? You've got to look at the severe cases, because the severe cases are the one that's going to impact you. So for his study, the very severe recession is about 1/3 of the case. I mean, 1/3 and 2/3, you may think, oh, 2/3 I have no recession. But 1/3 I have 5 millimeter recession. I mean, that 1/3 is very difficult to manage. And if it's your mother-in-law, it's worse. Every day when you go back for dinner, my tooth. When they placed the implants, they found out that the buccal bone loss is about 50%. And when they re-entered at 4 months, they still reported crestal bone loss. So what does this mean? With or without implants, at the crest is still going to shrink. You see? So this study shows that immediate implants are not that simple. Because in the early cases, they didn't do bone graft, they just put it in. So the concept of immediate implants slowing down resorption is not true. Because these implants goes in and still the resorption happens. Because why? Physiologic rich resorption still happens. Okay, remember the 3 characters? If you have trauma and infection, it's going to shrink. If you have bone or whatever, it's going to shrink. If your buccal bone is less than 1 millimeter, it's going to shrink. We learned that. So Stephen Chen, who is now our ITI president, 20 years ago, he does a lot of immediate implant placement. So this is what he reported. In 2008, he came up with this article, 42 immediate cases, no GBR. Extract, put in implant. Mean follow-up time, 1.5 years. Not too bad. It's not something that you place and then you report 3 months. Because 3 months doesn't tell you anything. 1.5 years, not so bad. He found out that majority of his patients, you see, his data, about 70%, 1 millimeter or less recession, which is pretty good. 0.5, 1 millimeter recession, sometimes you can't see. But that's not the true story. The true story is that 20%. Every 5 cases, he has 1 case that has crazy recession. Some of them went up as much as 2.5 to 3. Okay, so you have to know, you want to avoid this really severe complication. And he reported that when you have thin biotype, you start to see the recession more. You see his results. When you look at research or articles, you got to look at the tables and start reading it. And start coming out with your conclusion. I want to teach you that. So his report, he came up with some report. So thin biotype, more recession. His report is that if your implants is too buccal, you have 3 times more recession. Bless you. When your implants are too buccal, you get 3 times more recession. When you do immediate implant placement, and if you have no skill, when you put the drill in, the drill goes forward, right? Because the buccal bone is nothing there. So that's the tendency for an inexperienced surgeon in the beginning of the implant career. Try not to do immediate. Okay? Because this is what happens. Can you see this? It's too buccal. And when it's too buccal, you get recession. Okay? Why don't you wait 3 to 4 months more and then you place the implant properly? Okay? So ladies and gentlemen, why does this happen? Why does the resorption pattern happen? Again, the same group. These research guys are crazy, but they're so good. So from extraction socket healing, now they start putting in implants in dogs. Extracted the tooth, they put the implants. After 4 weeks, you see, the buccal bone starts to resorb. At 12 weeks, it goes down. So you have bone to implant contact, you have osseointegration, but the bone still starts to lose. Huh? So the conclusion is that immediate implant placement doesn't stop bone loss. Modeling, remodeling of the buccolingual walls in extraction socket even happens after implant installation. After implant surgery, the bone loss continues. Bone to implant contact that was established during the early phases of healing was later lost. Implant placement immediately into fresh extraction sockets, meaning immediate implant placement, failed to preserve the buccolingual bone wall. So this basically it happens. Another study that was done in Switzerland, okay, they looked at immediate implant placement in 93 subjects. And then after 16 weeks, which is 4 months, they open up the surgery to do a stage 2. Okay? This is for research. They want to see what the bone is like. This is very interesting. So they look at 2 things, the thickness of the buccal bone wall and the buccal gap of the implant to the buccal wall. This is their conclusion, guys. The conclusion is that when you do immediate implant placement, when your buccal bone wall is more than 1 millimeters, you're going to get good results. Okay, so what this means? So part of the conclusion is that when you go back to clinic, if you want to do immediate implant placement, your buccal bone needs to be more than 1 millimeter thick. Guys, I showed you the example. How much of our cases is 1 millimeter or less? 88%, right? We showed some studies with the CBCT. You use research to help you with your clinical evaluation. So we know that only 20% of the time have more than 1. You have to be very lucky. Okay. Next one. If your buccal gap from the implant to the buccal bone wall, the buccal gap is more than 1 millimeter. Okay. If the distance is more than 1 millimeter, you're going to get greater bone after 4 months. What does this mean? This means that you will not put your implant too buccal. Right? Buccal position, you're going to lose the buccal bone. So always put your implant a little bit laterally. That's what this study means. There's a hidden message to this study. Okay? I wanted to ask you guys, but let's not crack your brain too much, so I'm going to tell you the answer. Hidden message for this means that when you place implants in the aesthetic zone, if you want to do immediate implant placement, do not place a too big diameter implant. Right? If you place too big the diameter implant, it's like pushing the wall of your implant too close to the buccal bone, and then you're going to lose. This is the hidden message. Can you see how I'm helping you guys? From something like that, we learn so much. No one's going to teach you this, yeah? Because only Dr. Yo does it. Because I'm Kung Fu, I give everything. This means that if you want to place the implants, it has to be regular or the narrow size. Remember I showed you? So that you have enough space for the bone to come in. Because why? The concept for the aesthetic category is called biologic width. Okay? When the implants come out too much, okay, what it does is that it creates irritation to the bone and soft tissue. So too wide, too big, it starts having bone resorption. The interproximal bone also starts disappearing. So never do that. This is from this study. Let's take a look at hidden messages. So this study just looked at immediate implant placement, whether it works. So they took the tooth out, they placed the tooth in. And you see more palatal positioning. So they found that if the gap is more than 1 millimeter, at the end of the day, you're going to get nice bone after 4 months. If you place the implant inside, if you have a nice gap here, the bone will heal after 4 months. If you take the tooth out, you place the implant inside, you have a nice gap over here, you're going to get nice bone. This is what this study means. Same thing, if you take the tooth out, you place the implant, you have a nice gap here, the bone is going to heal. This is what the study wants to tell you. But the study never tells you this hidden message. So let's go back. We go back and we see. Immediate implant placement after 4 months. What can you see from here to here? The bone starts resolving 4 months later, you see? Huh? It goes in already, because this is physiologic healing. Next, do you see this? From a round, convex, it becomes concave. Can you see that? The hidden message is that the bone will still remodel. But is it still successful? Yes. But if you want to get aesthetic result with nice bone and gum, no, right? So sometimes you have to build the bone here. Hidden message. Another thing, see, it starts to concave in. So if you are in the aesthetic side, very demanding patient, you have to do something more than just putting in an implant. Okay? We look at hidden messages. Now, when we start looking at our Asian population, it's not so easy because we have already looked that a lot of the times we have less than 1 millimeter. Okay? This study came from Hong Kong. So this Hong Kong study looked at how thick the buccal bone is. Okay? And they found out that the buccal bone is always narrower than the palatal bone. And this is true throughout the world. Asia, Europe, America. What this study found out, which the Caucasian study did not report, okay, and this is what I found out too in my Singapore population, is that we have this tilt. Some tilt more, you see the tilt of the bone and the tooth, and some tilt crazy. Guys, do you want to do flapless and immediate on this? I wish you luck. That is why every time when you attend the overseas conference, the Americans and the Europeans, the lecturers don't tell you this. Only Dr. Yo, because I believe in this. That's why I get more WTF than anyone else. Because here in Asia, we get 33% of patients looking like that. I do not know about Myanmar, but already in Hong Kong and in Singapore, we got 20%. But I believe we are all Chinese, right? We are almost the same DNA structure. So that's why, you need to have evidence. You've got to learn from my mistakes, because I made a lot of mistakes. And that's the reason why, when I came back from Europe and America, I didn't do socket preservation. I waited 8 weeks, 10 weeks, and then I put the implant in because I followed my professor. But I found out that 20% of my cases, I get WTF. I said, why? Because of this. Because when the bone heals and I try to get the implant in, I got no bone for stability. Whereas the Caucasians are very different, I show you. So these are my own cases in Singapore, see? Can you see? How do we do immediate? Even if we do delayed, it's going to be a problem. See? Because how do you get stability when your direction is going to happen? See this? Yeah? Is it 100% of the cases? No, it's only 20%, but 20% can kill you. Every 5 who walk in your clinic will have this problem. See? That's why the aesthetic analysis is so important. Okay, so they did studies out there whether immediate implant placement needs to have bone graft. And the reason is that I think it's better because we treat it like an extraction socket. So they did these studies in dogs. In Sweden, I think they have a lot of dogs because they have been doing so many surgeries. So here they did split mouth, and they found out that the grafted sites tend to retain the buccal bone wall better than the non-grafted sites. So immediate implant placement or whatever implant placement, you need to get that 1-2 millimeters of buccal bone in front to get good aesthetic results. So Stephen Chen did a study. Some patients he used bios, some he used with a membrane and 10 no bone graft. And he found out that in cases with no bone graft, NG, no graft, you get more resorption than the grafted groups. Okay? And in the control sites with no bone graft, you get 50% bone loss. In the grafted sites, you get about 15 to 20%. Again, this study tells us another hidden message. You graft doesn't mean that you get 100%, but you minimize. Okay? The study that was done in Switzerland, 2012, 24 patients, they did immediate, but they added bone graft. and they concluded that 70% of the cases had good bone. So even if you do bone graft, you can only prevent that much. You still have 30% of the cases where you have no bone. Cases with intact bone showed favorable soft tissue integration, but had 1 millimeter more recession. Okay, so you do bone graft, it will help you, but it's still not good enough. So that's why immediate implant placement is so difficult. That's what this means. Any questions so far? We move on to type 2 and type 3. It's called early placement. Okay, you wait 8 weeks or you wait 12 weeks. You wait 8 weeks if you want just soft tissue covering it. Okay, you wait 12 weeks if you want more bone to come underneath. But sometimes I like 12 weeks, you know why? If the periapical lesion is so large, you want some time more for the bone to come in, because when you open up, then you get a WPF bone, you've got no bone at all, and then you have to do the bone graft. It's not very nice. So that's why a lot of my implant placement comes at 10 to 12 weeks. I wait usually about 3 months. Okay, Professor Boozer goes in at 2 months. The advantage of delaying your implant placement after extraction is this. You want soft tissue to grow over it. You want the infection to be cleared out of the body before you place the implant, right? Does it make sense? Okay. Now, this soft tissue is very important to me, because when I teach in aesthetic course, all my aesthetic cases, 99% of the time I do GBR for the nice volume. And when I do GBR, what do I need for closure? Do I want an open closure or a primary closure? You want primary closure. So the more soft tissue, the better. That's why I wait. That's why I don't do immediate so much. And you see now why my concept is different? Is it because I don't like or I can't do it? No, because my concept is that if I want to have the best aesthetic result, I do GBR. If I want to do GBR, I need to have primary closure, you see? So that's why you move backwards. The disadvantage is that when you wait 2 months, 3 months, the bone will start resorbing, right? We learned that. The greatest bone resorption is the first 3 to 4 months. So early implant placement is around here. I like it somewhere in between, but now I'm doing it at 3 months. So the advantage is that your infection before is now gone. You have better stability of your implant in the correct 3-dimensional position, because now everything is healed. The bone is not 100%, because the bone takes time. So the base of your socket, the remaining half of your socket, the apex, has already got bone. That's where you have primary stability in the correct 3-dimensional position. And what do I mean by that? Slightly palatal. So you see how early implant placement is to your benefit. Okay? And if you want to do GBR, you need the soft tissue volume for primary closure. Okay? So Professor Boozer came up with this article, followed 20 cases after 3 years, 18 cases, 0% or 0 recession. 2 implants had 0.5 to 1 millimeter recession after 3 years. So this is his results. These 2 cases to him is not so good, but to me it's already pretty good. And this is his aesthetic results. This one here, he got some recession, and this one here, he got some recession. His conclusion was that he did another study in same group of patients. So now, after 6 years, he reported that the 18 cases still had no recession. That 2 millimeters still had that 1 millimeter recession. That means it got bad at 1 millimeter to him, but it didn't get worse. He measured from CBCT that the successful cases had 1.9 millimeters. So the magic number 2. When you place your implant in an aesthetic site, you need to have that minimum 2 millimeters of bone in front. For the stability of the soft tissue and to prevent recession. So I'm going to show you now my case. Okay? So I will tell you stories right now, because this is so funny. This boy is only 21, 22 years old. And in Singapore, I do not know in Myanmar here, we have to do military service. Do you have to do that here? No. So at 18 years old, you have to go to the army. So it's like waste of time, but you have to. This boy, he was 21 years old, and then he was with his best friend. guarding, at the side. But Singapore is so safe. So, but these are all exercise. And then the sergeant walked, and then he did this to his friend. Hey, wake up, wake up! And the friend just got a shock. The rifle he was holding moved, and it went into his mouth. So he broke his tooth. They are not friends anymore because he broke the tooth. So when you break the tooth, he saw me. To cut the story short, you notice we have the fracture there, but we did force extrusion. You see, I brought the bone from there down at the bottom. Okay, so this is thinking outside the box. Because the patient said, you know what? Since I had to do orthodontics to adjust my teeth, I said, why don't we use this to extrude at the same time? So that we don't waste the ortho. So we did force extrusion. And once it comes out a little bit, so every time when the tooth comes out, you have to adjust the occlusion, stuff like that. The only time I stop force extrusion is that when I see an infection. Abscess, infection, straight away you stop, you have to take the tooth out. Okay? This is the protocol. It has to be clean. The force extrusion has to be clean. So you wait 2 to 3 months, sometimes 4 months. There's a fracture there. So what do I do? Socket preservation. Atraumatic extraction. 15C, periotomes. Now you'll use the entire day one, all the concepts that I taught you into this case. Took the tooth out, no socket preservation. Because when we took the CT scan, I say that we can shift this a little bit, it still falls inside the bone. But already you can imagine, at 8 weeks, you see how much the collapse is already, can you see that? Yeah. And this guy has a high lip line and thin biofilm. So I did my incision, okay? My incision is very conservative. I don't do this so much anymore now. You know why? I raise a bigger flap because now I like to do a lot of GBR. I need a big space. So I used to do small flaps, now I changed to big flaps. But the technique is still the same. Okay? At 8 to 10 weeks, now the base of the bone is filled. Now the base of the socket is filled with bone. You see, 50%. So that means that we can place the implant in the correct, ideal 3-dimensional position. Okay? 3-dimensional position is the key to success. Not too buccal, not too mesial, not too distal, not too palatal. So tomorrow, for you guys who are here, you have opportunity. I would like to share with you the Straumann technique. How do we use the drill step by step? Okay. Those of you who have no chance, I'm going to come back anyway. Okay. I'm going to make this Myanmar my home. Because in Vietnam, for the last 5 years, I've been to Ho Chi Minh 16 times. Every year they invite me 3 times. I go back and teach and teach and teach different groups of people. So I need to get a passport from Myanmar. We went in with a guide, we followed the principle. Step by step, okay, we did a pilot drill 2.2 for the round burr, we did the second drill. We follow Professor Boozer's 3-dimensional position, you see, slightly more palatal, okay? And then we finally get the last bit. Like I said again, why I like Straumann implant is that after every drill, you have this guide. After every drill, you have a guide. After the last drill, you have a guide because it tells you whether the position is correct. Remember, if you are doing it, remember the tip I told you? Functional cast, upper palatal, lower buccal, but for this case, my guide pin has to be just slightly over the lower incisor, right? You follow the occlusion that you learn in dental school. That is the guide. So I use the bone level implant with the SL Active implant surface. Okay, my last lecture before we end tonight, I'll tell you why I love Straumann so much. It comes in a nice liquid form, but the liquid is actually saline. You put it inside. Okay, you have a small dehiscence, but you have a big collapsory. So no matter what, you place in the bone. okay, you have to use the bone graft that is recommended. Here I use Bios, but Straumann has his own bone. Okay? But the principle, the concept here is the same. Again, I'm not selling the theory. So the concept is this: you get bone graft from the side. So you take a chisel, you scrape the autogenous bone, and then you put it as the first layer. And then your second layer, you put in the bone graft. And then the third layer, you put in the membrane. Okay? And then you close up. You see, it looks very thick right now. But the thing is that what you want to have is a situation where after stage 2, you put in the temporary crown, you mold it, and you get a case like that after 1.5 years. And then you look at the side profile, and you see, this is what I like. You have this bump. When we are in dental school making dentures, we have the root eminence. When we make the wax up, this is what we want. It looks perfect. Like a root. See that? The bump is your bone. Case number 2. Oh, this guy is so funny. In Singapore, we have 2 casinos. The Singaporeans like to gamble. All the Chinese from mainland come with the cash. This guy, he's a gangster. Do you know what a gangster is? Like a mafia. So he comes and he's this huge guy, like you and me together. Oh, and then he has all these tattoos. Oh, yo, I heard you are the best. Can you fix me up? I said, shit, wow. I said, yeah. I said, wow, I'm gonna be, he's gonna punch me. Oh, that's why I got his hands. He said, no, I don't want to do it. No, he said, fine. He said, what do I do? Because he got punched, Then I said that, look, I can't save you anymore. There's resorption, can you see? Then I said that, look at this lesion over here. He looks like Mickey Mouse. He didn't like that because Mickey Mouse is for sissy, it's for girls. So when I say that, you're like, oh. So I shouldn't say Mickey Mouse. I said, you have this lesion here. So see the Mickey Mouse? So he didn't like that. He doesn't like Mickey Mouse. November took the tooth out. 3 months later, we bled. You see the collapse? With the punch, can you see the root showing? He has resorption already. So we lost some gum and lost some interproximal bone. Can you see that? So we went in and we did the, you see the bone loss here? So we did the implant inside. You see how much bone was lost? And then we placed the implant in the ideal 3-dimensional position. I didn't even want to try immediate, because if this guy immediate is not correct, I wouldn't be here today. So that's the conclusion. Implant goes in, and we did the same principle. We did socket we did bone grafting, first layer, second layer, bio-guide, and then we closed up. Okay, implant goes in. Yeah, we did this under early implant placement. I took the tooth out, I come back 3 months. So I did stage 2. My stage 2 is very atraumatic. It's only a small punch, can you see? It's like half a moon, half a semicircle. All I want is to expose the healing abutment or the cover screw. And I take it out, I change to a new piece, and it looks like that. He got his first crown. He looks quite happy. This is how he looks like in 6 months. Oh, not bad. Huh? This is how he looks like in 1 year. Wow, I'm so proud of this case. But anyway, I can't do any mistake. Okay. After 2.5, he's about 5 years now. Look at the bone. But he is a good case. You know why? You see the implant and the bone is in the same direction. Huh? It looks great. So every 6 months, comes in to see me for his maintenance. So you have this big guy with the tattoo, you know, and then he'll talk about maintenance. He says, see my gums, but he cannot show people, right? Because he looks sissy and he looks too soft. So he always flosses and brushes his teeth. So the toilet, the restroom has to be no people. So his bodyguards will go in, clear everyone out, and he'll be there doing his job because he can't show anyone. You see? Right? And then he told me, Dr. Yong, I will protect you. Anyone bullies you and your family, I will come. So you don't disturb me. Don't call this guy. So he's been my patient for almost 6 years. A good guy, huh? Delayed implant placement. We're almost going to the end of the story. To be honest with you, it's going to be almost 70% of your cases. You know why? Someone did the extraction before. How can you control? That's why 70% of my cases are delayed. Someone took it out 10 years ago, 1 year ago, or whatever, and then they finally see it. I like those cases where I do the extraction myself, but you can't control. So delayed cases are the most common cases for you. Okay? The most indicated timing protocol. It's performed in patients where they are not indicated because of age, right? We talked about below puberty, you can't do it. You do socket preservation. Because of uncontrolled medical condition, you do delay. You want to make sure that the medical doctor cures his heart problem, diabetes, blah, blah, blah. It's very effective in cases where patients can't decide. I can't decide right now, or I don't have the cash. You do it delayed. You do it delayed, you do socket preservation, yes? But the problem is that if you don't do socket preservation, the ridge resorption pattern is very severe. After 12 months, 50% of the crest bone loss happens. If you do your own extraction and socket preservation, then you are fine. But if 70% of your cases are from somewhere else, then you are going to have a problem. And because of the unpredictable resorption, this is the problem. The problem is that the patient might have extra GBR, bone graft, block graft. And that's when the cost goes up, okay, because of the resorption. I like to do it in growing kids, okay, because like I said again, you do implants in a 17-year-old boy, at 22, he will look ankylosed. And then you're going to be faced with a medical problem, medical legal problem. So let me share with you some remaining cases of mine that I do with delayed. This lady over here looks quite easy. See that? I look at that because the extraction was still not completely healed at the top. So I said, you know what, that's so easy. So I did not raise a full flap because the buccolingual ridge width is so nice. And then slowly when I placed the implant in, when I used my finger, I was like, oh, something is on the outside because the bone is not uniform, parallel. It's like an hourglass. So you see, we have to graft that side. So I had to raise another flap, raise a vertical incision, place the bone at the apex, and then we close up. I don't need to have complete primary closure. This is how the patient looks like after 1 year. See, delayed, sometimes you got to be careful. The resorption pattern is a bit different. But it's fine, it's actually quite okay. 3 years, it's okay. So my bone graft over there kind of worked. Case number 2, another story. This is the lady who had the lucky tooth. She's 55 years old, has been wearing denture for 20 years. And she said, Dr. Yo, I think it's time for an implant. I said, why? My daughter is getting married. I said, oh wow. So she wants to look good. Yes? So we want to help her. Can I take this tooth out? No, right? We talked about that. Take this tooth out. I'm not going to get the money. I will pay you. I said, okay. I want my money, so I need to keep that tooth. We took the CBCT. We found that the tooth was very, very bad. So we said, that's no issue at all. But look at the resorption pattern. It goes in straight away. So when you open up and you see that, it's very huge, very collapsed. But you still can put in the implant in an ideal 3-dimensional position. All right? So we did the same protocol. Implant goes in, bone graft. Okay? Implant has to be in a correct 3-dimensional position with bone graft. Same technique. Close, cover screw. Stage 2, we expose this. Okay? And then we decided to do a new crown for the 2-1. And this is how it looks like after the provisionalization. This is what you want. You want your implant exit to be slightly palatal to the incisal edge. Because later down, when you start learning about implants, the prosthetic ways, okay, there's cement retain and there's a screw retain. Screw retain, you need to hide the screw on the palatal side of the incisor edge. Because if your screw retain is on the buckle, then it looks awful. So this is how it looks like on the day of issue. Not bad. See, my implant is still far away from the tooth. That's why we need the CT scan to tell us. 1.5 years. 4 years. See that? See the bone? You see the bump? When you look from the side. So this lady, her daughter got married, okay, and she was very happy. And every year she was saying, "Wow, it looks very good." She sees me every 4 months. After the first 6 months of maintenance of that post-op care, I started to realize who her daughter married. Daughter married this really good chef, business owner that owns a chain of restaurants in Singapore called the Paradise Group. I do not know whether you know. They sell Chinese food. So the daughter married this guy, and I got a discount card, 50%. Now you know why I look so round. So you see, my stories are very exciting. I love my job. So now I'm the guy that goes in, yeah, so the boss, mother-in-law is my daughter. So I get good discount. My conclusions for today, ladies and gentlemen, before we semi-close up, because I like to have a nice summary of what Straumann can do, is that immediate implant placement can be done. When you want to do flapless, you really have to choose your case. You know right now that 20-30% of the Asian population have that slight angulation problem. If you do immediate and flapless in those cases, you're going to be a failure straight away. So CBCT analysis you have to find out. Okay? I like to do immediate implant placement if there's a low aesthetic demand. Low lip line, thick biotype. Primary stability is very important because when you want to do immediate and you can't get a good stability in the correct 3-dimensional position, forget it. Stop, put in the bone graft, and then that's it. You do it delayed. You have to tell yourself this. So I always warn my patient, let me try. There's always a chance that I can't get a good position and then we have to stop and then just do socket preservation. Early implant placement to me is the most recommended option. Some people were asking because I like to come in at 3 months. Why? I have nice soft tissue. I like to do GBR for aesthetic cases for the reasons I show you. And primary closure is very important. So 3 months is the time. Delayed implant placement, guys, you know it works, but it has a lot of resorption pattern. Yeah? So it's very, very tricky because some cases you have no choice. You see, sorry, but we have to do a block graft. Okay? So we have timing protocol today. What we did today was basically talk about myself, talk about ITI. You saw how powerful it is. Talk about how medical history and analysis and treatment planning is so important. It's so boring, but it's so important, especially in our career. To me, in my 22 years, I say this, you have to do it correctly at the first time, because if you do shortcuts, then it will be shortcut all the time. But if you have the correct mindset, your journey is going to be like that, because this is you, this is part of you. We talk about medical history, we talk about treatment planning, why it's so important, how to look at x-rays, how to even analyze that the mandible here. It's not easy, you have the undercut, right? Stuff like that. We talked about the socket evaluation, we talked about socket preservation, we talked about timing of protocols, immediate, early, and late placement. So you have roughly the full range of what the basic implant placement is all about. Okay, I hope to come back in the second half of the year where we really focus on aesthetics and do more hands-on. Okay, I'm looking forward to it. So I hope you guys want me back because I'm so funny and such a nice guy.
Don't bring the bodyguard.
Don't bring the bodyguard. I'd like to thank you for your kind attention and for you guys tomorrow who are coming. I look forward to see you. So before I end, I would like to share with you why I choose Straumann implants or why my patient really loves and benefits from this. Straumann is not here to listen to this, but I would like to share with you why it really works for me. So why I love and my patients really love Straumann implants. So I would like to end the next half an hour to 45 minutes to tell you how this company basically can actually help you. Okay? Because for me, I come in here as a educator. Okay, I'm not here to sell implants. I'm here to sell concepts. But every concept needs to be supported by good materials. When we look at implant dentistry, okay, it used to be what the doctor tells you, but not anymore. We call this a multidisciplinary effect. Okay? You have the clinician, which is us. We have the patient. We need to communicate with the patient, diagnosis, treatment planning, aesthetic risk assessment, SAC2, blah, blah, blah. We need to learn to see what kind of treatment approach, early implant placement, socket preservation, GBR, bone grafting, we learn from us. We need to know what kind of biomaterials to use. You want to use Straumann implants or not, or you want to use Otis products, BioOS, blah, blah, blah. You need to know all this before you tell the patient, this is what I'm going to do for you. And then you decide, okay? Straumann, basically, they started off as a replacement company, meaning they only came out with implants. And then they came out with their own products for regeneration, for GTR, which is around natural teeth, perio, and GBR, around implants. And then now they started having the digital option, CAD/CAM, 3Shape, guided surgeries. So my focus today, since I'm more of a surgeon, is to talk to you about the replacement approach. The dental implant systems, I will talk to you very, very briefly today. Tomorrow, you guys are going to be here. I'll talk to you in detail. You have different designs and different surfaces. In a very simple summary, Straumann is so great because they have two kinds of implant designs, tissue level and bone level. If your clinic only wants to have one implant, it's fine. I started with tissue level implants. The problem with tissue level implants is that you have to be the best damn surgeon in the world. Because why? You fix your restorative margins. If you place it to left, to right, if you are stuck. If you place it too coronally, you are stuck with a short height. Then, like I said again, you can't build your ceramic. You can only have a gold crown. Things like that. So the problem with tissue level implants are just meant for the specialists. But Straumann wanted all of us, the early users and the late users, to enjoy. So that's why they kind of chop off the whole thing. Then people will ask, why don't we just have bone level implants? Then I'll show you why. Because the best results in terms of the soft tissue is actually this. Because you bring the crown margins away from the bone. You bring the plaque, everything away from the bone. And that's why the bone and the soft tissue is so nice, so thick. Okay? But like I said again, there's advantages and disadvantages. Okay? So the implant design for Straumann came out like that. Okay? They started off with the tissue level, and then they have the bone level, and then now they make it tapered. So to me, in my clinic, I only have these three configurations. Okay? I spoke with Mr. Jason, Charlie, and we said that most probably we're going to start with the bone level ones first for you, but eventually we are hoping to bring this tissue level. Okay? So I explained to you in summary what tissue level means. Tissue level is a one-piece implant. So you have the rough component and the smooth component. So it's all inside. You have the bone component and you have the soft tissue component. When we place implants, I spoke to you about biologic width. When the implants are placed inside with a cover screw and you cover it, everything looks fine. Because you know why? There's no environment. The implant is not exposed. That's why the bone and the soft tissue inside is very stable. But we know with implants, you have to put a crown over it. Right? You do stage 2, you make an opening. But once you do that, you expose the saliva, the food, and the environment. Okay, depending on where the crown margin, where the plaque likes to stay, the plaque from here goes all the way down, and then it will form a circumference of biologic width. That's why the 1.5 came about. Remember 1.5? You don't really want to put the implant too close to the adjacent teeth, because this distance is about 1.5. You put it too close to the adjacent teeth, at 1.5 will remove the bone on the adjacent teeth. If you put the implant too front to your buccal bone, remember the study that showed you cannot choose too large the implant, you need to have space. If you put your implant too close there, then 1.5 will remove your buccal bone. You see? Theory. Okay? So the biologic width is this. Okay? Once the implants are exposed, you're going to lose some bone. This bone remodeling is not disease, it's just natural modeling. That's the reason why the tissue level brings the gap all the way up. So the plaque accumulation is on the top. There's no gap. That's why for tissue level implants, you see that the bone loss is actually very minimal. Because for a bone level implant like that, okay, this is where the bone level is, the plaque. So you have some bone loss. So the tissue level implant, the plaque accumulation is here, not here, because this is one piece. Can you see that? Okay? And the aim is to move the micro gap. You want to move the gap away. Because there's not going to be a situation where the lab is so good that you have 0 millimeter gap. Not with the crown even. So when the gap is far away, the bone is better preserved. Okay? So let me show you how a tissue level implant looks like. Patient comes in, this is a delayed implant placement. Can you see the shrinkage already? Same thing, CTs, X-rays, we check the bone, we measure 10 millimeters, that's a fit inside. We can use a wide diameter implant. We still have 1.5 on each side, play around with. Put the implant in, tissue level, you see how nice the soft tissue. Healing is amazing. Because you know why? The gap is on the outside. Patient just floss very easily. Patient doesn't have to floss all the way down. Can you see that right now? Okay? Can you see that? Why we still need the tissue level implant? Second design, bone level implant. Okay? The restorative option is flexible. Why? You can choose the margins to start here, start there, start at the top. You choose different heights, 2 millimeters, 4 millimeters. You decide where you want to start the restorative margin. But the plaque would always be here. The food tract, the saliva plaque will always be here. And because of this, the 1.5 starts. Okay? So Straumann basically did the implants by chopping off the head. They came up with this. So BLT is very quite new. It's about 2017. Okay? It's about 2 years old. So bone level, tissue level, great. Bone level you have to bring down, but the thing is that the margin is here, and then you get an influence there. So can you see that? If you were to put a tissue level implant at the level over here, your bone will stay here. But if you were to put your tissue level implant, submerge it inside, it's like bring your gap lower, then you're going to get this remodeling. Can you see this concept? This is not implantitis. So that's why for cases where in the beginning of my career, I only have tissue level implants and I have soft tissue biotype and I want to hide the margin. Sometimes what we do is that we put the implant very, very deep, okay, to hide the collar. And if you are a skilled clinician, that's fine. But if you are not, you put the implant wrongly and then you're going to lose the buccal bone. So that's when some clinicians say, okay, no, not all surgeons are that experienced. That's why they decided to have the bone level. That's why bone level is only about maybe 10 to 15 years old only. Because Straumann started with tissue level implants. Okay? So you can see this. You push the tissue level down, you're going to get remodeling. It's not infection bone loss. You know why? You see where the bone is? It's still at the rough surface, you see. No? It's just that now the gap goes down so low, this will just remodel itself. Okay? So bone level is great. Bone level will help to hide that smooth collar margins, and bone level will enable you to do GBR very easily. Because if you place a tissue level margin, what happens is that your GBR has to go all the way up. Bone level is great because if you want to do GBR, your closure is just like that. If you do a tissue level implant, your primary closure is that you have to bring everything all the way up. It's not easy. So that's why tissue level implants in the aesthetic zone, it's not easy. So what Straumann and some of the top implant companies do is to move away the micro gap. So that's why, you see, the micro gap is now here. They move it inside so that they will minimize that 1.5. Okay, but this is still about 1 millimeter. So you still get sometimes some remodeling here. So let me show you a case with bone level implants and how is it being done. This case you saw very nicely. I'll do it quite quickly. And then you have a very nice case. Straumann in the last 2 years came out with the BLT. This is something that is very interesting, and I find it very useful for our Asian patients because we have less bone. I like it in tight spaces. I like it in cases where you don't really have so much space. And we know right now that sometimes the bone and the direction of the tooth is not parallel. By using a tapered implant, you have less fenestration or the bone effect. So I like BLT when you have limited bone. The advantage of BLT is that with the tapered design, when you screw it inside, it gives the clinician more confidence because it's very, very stable, it's very hard. Whereas the parallel wall one, sometimes you get still movement. So the BLT, if you guys want to do it, is great. I mean, it's something that you can just keep one. Maybe in the future you can just have BLT and a tissue level, that's it. Okay? I hope tissue level comes in. So can you see that? The BLT really helps you in very, very tight spaces. Another design that Straumann came out, which really helped my patients, is that when I encounter with a very tight space, I like the small implants. So they came up with this reduced diameter, almost like mini implants, but they are not. Okay? Now sometimes when these small implants are being required to use in large gaps, why did I say this? Are they indicated? Yes. The patient, like we shared earlier, is already 80 years old. You don't really want to do big flaps, GBR. You don't need it, right? Patient just want to have a nice tooth. Patient maybe has cancer or something and he only has 6 months to live or 1 year. He said, I just want to do something for myself in the last 1 year of my life. So we do something very simple. So in a case like that, you just do something like mini implants. You do a reduced diameter implant and then you don't have to do any GBR. That's it. Sometimes flapless. You keep it very easy for such cases. Or some patients who have medical problems, with all the money in the world, but all these blood thinners and stuff, you don't want to raise a big flap. You use guided surgery, flapless. You place a small implant inside without GBR. Very easy. Eh? So small implants are very useful. But small implants to have a big tooth is very dangerous. Okay? So it's like having a toothpick implant, but the head is so big. That's why sometimes mini implants don't work, because they break. So implant fracture is a problem. Straumann came out with a new material. They call it zirconium. Zirconium. Okay? Titanium zirconium. They are not white implants. They are the same color. It's an alloy. It's the metal mixed together. But they found out that this implant is so strong that you can't even break. So it's good for cases like that, where you have a small body with a big head, or patients with huge muscle at the side, the masseter, and they clench and they grind. These are, you've got to use the zirconium implant, or the rock solid, we call it. Yeah, rock solid, that's the name. So this guy, he chews so hard that I say, you know what, use the rock solid implants. Okay, so we have the design. We have tissue level, we have bone level, you have BLT, bone level tapered, you have reduced diameter, and you have the rock solid. Okay, so you see how strong this whole brand is. The other advantage of Straumann implants is the surface. This is something for all of us here. Straumann came up with an improved surface. Before, their implant surface is called TPS, titanium plasma spray. They spray the titanium balls onto the titanium implant. They make it into ball. Okay, because rough, bone-like rough surface. Okay, Brennemark implants are all smooth, so we are moving away from smooth implants. But they found out that this kind of spraying effect it's not as effective, because sometimes the balls drop off. So in order to make the implants rough, there's another way. They call it subtraction. So they use sand and then blast it on an implant and make it rough, and then they wash away with acid. That's why they call it the SL active implants. They use large sand, they blast these implants, making it hollow, rough, and then they use acid to wash it away. SL active. And they found out that this SL active surface implants is so good that after 8 weeks you can start loading. Because the old Brandemark implants you need 3 to 6 months. So when Straumann came out with the SLA implant surface 20 years ago, wow, everything changed. And it's now the patient gets the crown faster, loading faster. And then Danny Boozer came out with this 10 years. 10 years studies of his patients. 303 patients, 500 implants. And this is what he looked at. He looked at survival and success. Guys, 500 implants, his survival is 99. But this is not something that I like to look. I look at success. Look at his success. Wow. He didn't have any loss of implants. He just lost bone, and he considered that as a failure. Can you imagine? To me, this is great. Out of 511 implants, maybe 11 implants just had some bone loss or some pain or something. The rest have no bone loss, nothing at all, because of the SLA surface. And they were all tissue level at this time. Okay? So this tells you that's why Straumann is so great, it's because they depend on ITI people to do research, and they came up with a 10-year studies. Who comes out with this? No one. Because why? They are so afraid. Because if they come out and their study only have 80%, then it's not good. SLA surface, they want to make it even better. So they say 8 weeks is not enough. Straumann has this problem. Their problem is they want to get better, they want to be number one. They want to get better each time. So 8 years ago, 10 years ago, they came up with this improved surface. They want to even make it even faster. Because why? The titanium surface is very reactive. It's a very reactive metal. When you open the titanium, when you open the box and it's exposed in the air, the oxygen in the air combines with the titanium and becomes titanium oxide straight away. And they found out that this oxide slows down the healing. The osteoblast cannot start on it. But that's how it is. Straumann decided to remove this oxide layer. So they manufacture these implants in a sterile environment, nitrogen gas. Nitrogen is an inert gas. They manufacture the implants in a nitrogen environment, and then they store it in sodium chloride saline. So no oxygen. So when you open it, there's still a layer of sodium chloride. You put it inside, no titanium oxide. The healing time, they found out it reduces by half. From 8 weeks become 4 weeks. Wow, so fast now. Yeah. So it's very hydrophilic. It gets very wet very easily. See, in the SLA surface, this is a nice picture. The water cannot go into the groove of the subtraction roughness. It slowly you will start coming in. So what this means is that the bone will take some time to go inside. But with the SL active implants, you see, when you drop it, it becomes wet straight away. Because it's so hydrophilic that the blood vessels or the blood can actually go in here. And once you get the blood in, the bone or the osteoblast goes inside straight away. That's why the loading is now at 3 to 4 weeks, not 8 weeks. So Straumann came up with this study, which I was there. I was there to actually witness this study. So he did it in animals, and he looked at 2 weeks, the bone level implant, the SL active implant has more bone to implant contact as compared to the normal SLA implant. At 4 weeks, it's the same thing. But guys, look, at 8 weeks, no difference. So it doesn't mean that SL active implants is superior all the way. What it means is that for the first 8 weeks, it will make the bone heal, and then that's it. Everything is the same, because it's the same roughness. What does this mean in clinical practice? It means that I would like to have in cases where patients cannot wait. Some patients, they have so much money, they don't want to wait. Say, doc, I want to have my crown within 3 weeks, something like that. SL active. Okay? So, Straumann came up with this theory, and it's very interesting. They found out that when you place the implant in, you call it primary stability. So it's like putting the implant into the wall. But it's not as easy as putting a nail into the wall, because in a bone, when you drill, you have necrosis. It's normal. You are injuring the tissue. So the surrounding, you have necrosis, you have bone death. So the primary stability in green goes down and down and down. That's the primary stability. But the bone, because it's a living organism, it produces new bone and starts attaching to the implant surface. They call it secondary stability. Can you see? So the secondary stability will start coming up, the primary stability will go down. They found out that a lot of the failures happen at the second and third week. So they call this the implant stability dip. They came up with the SL active implant because they wanted to promote an earlier secondary stability. Can you see the blue line going towards the left? So the dip right now is very little. So that's why in cases where you think that the healing is not so great in the beginning, I use active. What kind of cases? I like it in patients where they have medical problems, like diabetes, slow healing, smokers. I just spend a little bit more, get the healing in as quick as 2 to 3 weeks. But I still wait long. I don't load at 4 weeks. I just want the initial healing to happen. I like it in maybe elderly patients, 70 something years old. I do that. So SL active implants are great. Smokers, mild to moderate medical problems, elderly patients. If you are using short implants or narrow implants, you want the best healing, I use active. If I want to put implants in a stage augmented site with a GBR, I use active. In fact, right now, my clinic only has active. But if the patient can't afford the extra price, I charge them as a normal SLE. You understand what I'm saying? Because I just want the best for my cases. This is what we have to think. And because of this Straumann technique, you place less and less implants. So you make the treatment more affordable. Because before that, the planning was I put 10 implants because maybe 5 might fail. The concept is very different. You understand what I'm saying? With the Brandemark olden times, the implants were not so great. I placed 10 because maybe 5 fail. Wow, you can't talk about this. Right now, if I place 5, all 5 must work. So it changed the concept of implant dentistry. Then starting, we can use shorter implants, narrower implants. Right? Ladies and gentlemen, you guys have been great. Thank you for really listening to me. 9 o'clock all the way to now. I really thank you for your kind attention because this is really great. My passion is to talk.